think we may not have time. I'll just show one slide. Keep going, keep going, keep going. Last two. I'll just run the names alone. I will not discuss in detail. There are a few landmark trials. Go to the first slide. Landmark trial. First one. Okay. Next. See, you have certain trials which talk about screening, early detection. You have certain trials which talk about localized organ confinement. There are trials which talk about locally advanced. There are trials which talk about metastatic disease, oligometastasis, non-oligometastasis. There are some trials which talk about the need for NPMRI and all that. I'll just quickly run through. Next 5 minutes, we'll wind up. By 12:30, I think we should call it a day. See, there are a few screening trials which you should remember. One is ERSPC trial, the European trial, PLCO trial. They both talk about the need for a screening. Last week, we talked in detail about the number needed to treat, the number needed to screen, and all that for NNT, NNS for CF prostate. Both of them, both ERSPC trial, PLCO trial, should be known to you because these are the ones which talk about the need for a screening in CF prostate, whether screening is really effective, the screening is really useful in prostate cancer, reducing the prostate cancer specific mortality individuals or not. Okay, so these trials, you should next slide. And the screening chemo prevention trials. You should know about this PCPT trial, prostate cancer. It's one of the landmark trials which talked so great about finasteride, and then the reduce trial which talked so much about the need for dutasteride. There was a time when this finasteride and the dutasteride were being prescribed right and left in patients with we see a prostate, thinking that it will reduce the microvascular density, thinking that it will downsize the gland. These drugs were used so rampantly. This PCPD trial, reduced trial, you should know. And then the other chemo prevention trial, selenium trial, that is called a select trial. Selenium and vitamin E cancer prevention trial, that is select trial. So chemo prevention, you talk about finasteride, you talk about reduced trial, dutasteride trial. Finasteride trial is PCPD, dutasteride trial is reduced trial, selenium trial is select. These are the three landmark trials which you should know for chemo prevention. So for screening, you talk about ERSPC trial and the PLCO trial. And then for screening, you talk about chemo prevention, you talk about reduced trial, you talk about select trial, you talk about PCPD trial. Okay. Then the next one. Yeah, Roshan, busy, huh? Okay. And then subsequently for locally advanced prostate cancer, like in our case for that matter, we talk about prostate cancer intervention versus observation trial. Who are the ones for localized cancer, you put them on active surveillance? Who are the ones you put them on intervention? You can talk about, you please read about private trial, read about Scandinavian trial, read about a protected trial. These are three trials. We don't have time to discuss all this in great detail. Anyway, I'll ask Surya and Puneet to share this PowerPoint with you. You can just go through that when you find time. And then these are the trials which you should know when we talk about a localized or locally advanced pivot trial, Scandinavian trial, and the protect trial. Third, next one. And then you have a metastatic disease, which is hormone sensitive. We talked about charter trial. We talked about latitude trial. You should know about the stampede trial, the various arms in stampede trial, various arms that we have. We have a ADT in one arm, ADT docetaxel in another arm, ADT abiraterone in another arm, ADT radiotherapy in another arm, enzalutamide, use of enzalutamide, apalutamide. All these you should know. Charter trial with ADT with docetaxel. You should talk about latitude trial, ADT with abiraterone. All these trials you should know. These are all mainly for the hormone sensitive prostate cancer. The next one. Yes, a hormone resistant prostate cancer. We have affirm trial, prevail trial, profile. Not possible for us to remember everything. Maybe one or two here and there, here and there. I'm sure you must all be. Affirm trial is a very, very popular trial. Enzalutamide trial, prevail trial, and then the vision trial, lutein, whatever. Read about it. I'm also not very sure about it. Please go through all this. Okay. Fine. But if in case they ask you, you should be able to say one or two here and there, here and there. Okay. Next slide. Non-metastatic. Read about all this. Spartan Prosper trial. Next. Yes, this is again another important trial that you should all know. Promise trial and precision trial. So they are the ones. The earlier days, transrectal ultrasound was the investigation of choice to make a local staging. After this MRI came into vogue, endorectal MRI was being clearly defined as the investigation for local staging. And then there's MPMRI, multiparametric MRI came into picture. And then they said that MPMRI not only gives you the local staging, but also gives you the characters of the tissue within the prostate gland that will be able to give you a pyrite score, and that will tell you without biopsy, it can tell you whether it is benign or malignant. Now, there are a few centers that still do MPMRI and go ahead without a biopsy. We have got enough published papers on that as well, though some examiners may not accept it. And especially when you talk about the radical prostatectomy with an MPMRI in your favor, you should be extremely careful. You should be very, very careful in saying that. By and large, it's always safer for you to get away in the exam by talking about the biopsy, confirming the diagnosis, and then planning a definitive treatment. But if you say MPMRI, pyrites is 4 and 5, that means there is 97% chance that it will be only malignant. But again, on the corollary, there is a 3% chance that it need not be malignant. No. What if your patient who has had a radical prostatectomy falls in the 3% category? That means you're unnecessarily doing a biopsy in this individual, unnecessarily doing such a morbid procedure in this individual, isn't it? So you'll have to be very, very careful in choosing which is the always in the exam. It's safer to go with the trust guided biopsy before the radical. That should be the bottom line message here. Trials which talked about the role of MPMRI and trust in trust-guided biopsy is Promise trial and Precision trial. Both have categorically shown beyond a doubt that MRI is definitely better than trust as far as your diagnosis is concerned, and MRI targeted fusion biopsy or a trust-guided biopsy, if you compare in two arms, MRI largely outweighs the benefits that a trust can offer. So it is always better. Between the two, MRI is preferred, definitely. Okay. Next slide. This will be a summary of all the, this and the next one more slide will give you a summary of all the various names of the trials and various arms which are being used. Please, I will ask Surya to share it in the Qs group. I would request send the invitation to all of them.
Yes, sir.
Let all of them join the Qs group. Whoever has participated in this,
yes, sir.
The 100 and odd participants, you can always ask them to get themselves added in the Qs group so that you can share this PowerPoint in that group so that students can get benefited as well. Okay.
Yes,
they can
sir.
always go back and read all this in greater detail leisurely whenever they have time. Okay.
Yes, sir.
And we go through the chat part now. Any questions which are left unanswered, we can quickly run through the next 2-3 minutes and wind up.
Sir, one person has asked, there are multiple guidelines, sir, like AUA, EAU, and NCCN for urological malignancies. So, which guidelines to follow is what he's asked, sir.
No. We were under the impression that the NCCN guidance is the one which is very well followed universally all through. But somebody here mentioned one Cambridge, some other criteria. Always go with NCCN, which is safer for you, widely practiced all over. NCCN and D amico risk stratification. That is the one which you'll have to follow.
Yes.
Okay, for risk stratification, undoubtedly it is a D amico risk stratification. A low, intermediate, and high risk. For the subclassified is very low risk and low risk, favorable and unfavorable intermediate risk, high and very high risk. This will be the widely accepted risk stratification, which you'll have to tell in the exam. Yes. And for management part, of course, a prostate has got so much of options available. You fix up one particular management protocol for your department, and all the PGs, exam going PGs appearing for the exam from that particular center should all speak the same language. I say abiraterone, the other says docetaxel, the third one says bicalutamide. And if all three of us say it's a department protocol, your internal examiner will not be able to come to your defense at all. Isn't it? Yes. So always speak the same language. All of you sit down together from the same university, same department. If there are 6 PGs appearing from the same department, all 6 of you should sit down together and you should form your own department guidelines so that the internal examiner will be able to come and defend your statement. Otherwise, if Rajan says one as a department protocol, Surya says totally different one as a department protocol, how can I support any one of them? Isn't it? Yes. It's extremely difficult for us then. So, CA process, that's the reason why we thought we'll split CA process into 2 sessions. Try to cover one particular segment in each of the sessions. The initial one, we talked about so much about the epidemiology and all that. What is CA prostate? What is serum PSA? When is serum PSA elevated? When not elevated? Normal serum PSA with serum with the malignancy. all that we discussed in the last class. And now we talk about management issues now and the trials, landmark trials, which you should. The next question, if there is anything at all.
So one more question, sir. For active surveillance in Epstein criteria, the percentage core biopsy is 3 out of 6 scores, sir.
Yes.
He is asking whether if it is 6 out of 12 core biopsy, whether we can still go for active surveillance.
That is what they said in another classification. They would have said 34%.
Yes, sir.
So that means 34 to 50%. If you take 12 cores, that means it is 6 cores, less than 50%.
Role of Briganti and MSKCC nomograms.
Yeah. You have anything to say, Rajan, about this? What is the other one? AEO for logical maladies, which guidance to follow? See, don't see the classification. You believe in one philosophy and go with it. That's all. Okay.
Yes, sir.
What else?
So when to do MPMRI, MRI pelvis, BP.
By BPMRI and MRI pelvis, sir.
Biplanar, multiplanar.
Somebody has written, Sridhar sir is the observer for our Tamil Nadu Medical Council certificate, the credit points. So that's the reason why. Okay. Have you taken a snapshot with when he is there around?
Yes, sir.
Yes, sir. Yes, sir. We have it.
Wonderful.
Sir.
That's enough then. Okay. Any more questions? Anybody? Quickly, we'll wind up in the next couple of minutes.
So role of
Sir,
MRI pelvis.
Sir, in a locally advanced CA prostate, we should go for neoadjuvant hormone therapy or radical prostatectomy.
No, never. See, when you say it is locally advanced, there are two types of locally advanced. One is just involvement of seminal vesicle alone. The other one is regional node involvement. Both will be actually a locally advanced disease, isn't it?
Sir, if pelvic lymph node involved.
If pelvic, that is what I'm saying. Pelvic lymph node is what external leg. See, in our patient for that matter, this patient that we discussed now, is it locally advanced or is it a metastatic disease?
Sir, in PET scan, in PET scan, seminal vesicle involved and one external iliac lymph node involved, sir.
That is what I'm saying. That is what I'm saying. If in case you have a seminal vesicle infiltration and the PET CT also shows a small lymph node, 1.52 centimeter lymph node, which is excisable.
Okay, sir.
The original concept was that when I was a postgraduate, if there is a nodal mass, don't do at all. There is no role for radical prostatectomy. Then they started extending that to, if it is excisable, then we remove that nodal mass. Anyhow, we are going to do pelvic lymphadenectomy. That big nodal mass, if it is there, you can excise that also. Okay, along with radical prostatectomy. The present concept is that if it is a 2 centimeter nodal mass, give neoadjuvant chemotherapy, downsize that, and then do a radical prostatectomy along with excision of all the lymph nodes. That is again another acceptable option these days.
Okay, sir.
Is that clear now? Whereas the patient that we have in hand has got such a huge mass which is not accessible at all. Here there is no role for radical prostatectomy with removal of the lymph nodes here. Here you have to necessarily go for a downsizing of the mass. See how much of downsizing can actually happen with that and then take it from there.
Okay, sir.
The role of MRI pelvis and role of bone scan.
That's what. Bone scan has got no role to play these days. Nobody does a bone scan these days because bone scan will only tell you the bone involvement. Whereas a PET CT will tell you, PSMA PET CT will tell you the bone involvement, the nodal involvement, soft tissue involvement, distant organ involvement, head to foot, everything will be known in that. So if in the exam you should only talk about ideal circumstances, you cannot talk about the affordability of the patient. Bone scan will cost you only about 4,000 rupees, whereas the PET CT will cost you anywhere between 16 to 25,000 rupees.
Sir, for the metastatic evaluation, if PET scan not available, so better investigation is a CCT whole abdomen or MRI?
If PET CT is not available in your setup, the ideal answer should be refer the patient to center which has got a PET CT. Let the patient get the PET CT and come back to you. You can even travel to the next district and get the PET CT done, and he can always come back to you again. So that should be the answer that you should give in the exam. Okay, you cannot get away. But if in case PET-CT is not available anywhere at all, and you are not in a position to, such a hypothetical situation where you are not in a position to send the patient elsewhere, the CT abdomen will give you a better delineation of your nodal status as well as the bony involvement. Whereas MRI will tell you, MP-MRI will tell you more characteristics about the pyrite score of what is happening within the prostate gland, and also will tell you what is happening in the nodes. Is that clear? But both will not tell you what is happening beyond the abdomen.
Okay, sir. So means in PET scan availability, if not available, then we should go for CCT whole
MRI.
abdomen.
No, you can do CT abdomen, you can do CT abdomen is always better for us because interpretation is easier for us. MP-MRI will do only if the biopsy is not being done. If already the biopsy is done, what is the need for MP here? Multiparametric is not required at all here. Irrespective of pyrites 1 or 2 or 3 or 4 or 5, again the tissue diagnosis is already obtained.
Okay, sir. Sir, for I'm asking for metastatic evaluation only.
That is what MP-MRI is not required. You do MRI of the abdomen. MRI of the abdomen will be useful here. MRI of the abdomen will tell you, especially if you do a GADO enhanced MRI, it will tell you up to 0.5 to 1 centimeter lymph node also will be picked up in that, especially when PSMA PET is not available. But the problem with that is that you will not be able to interpret this finding. You'll have to depend on the radiologist for that. The best thing you can do is a CT whole abdomen with oral and IV contrast. If the creatinine is normal, will give you a node which is as small as 0.5 centimeters. So you can always say that I will do a CT thorax and a CT whole abdomen, oral and IV contrast. That will be the safest way of.
Okay, sir. Thank you.
That will also tell me about the lumbar nodal metastasis, lumbar vertebral metastasis.
Okay, sir. Thank you.
It all depends on how you argue it out. In the exam, see a prostate, anything you see, the examiner will not deny it outright, will not reject it outright. They will just wait and listen to you for a second and see what logic you have got behind whatever you have uttered, and see whether that logic is acceptable enough for them. And if it is acceptable enough for them, they will accept it. Okay? That's how it will be in the exam. Unlike our MBBS or MS, where you miss one visible gastric peristalsis, you will fail. Miss one VIP, one finding you miss, you will fail. In MCH level, it will never be like that. MCH, they will only look at how you approach this particular candidate. I told you earlier in the morning today, two candidates. One calls it a benign hard firm nodule. The discussion will go in line of BPH with nodule. The other candidate says it's a hard nodule. Example to go take the discussion in line of CF prostate. Okay, that is how it will be. Because what is firm for you may be hard for the other person. What is hard for you may be firm for the other person. How you approach that particular case is what really matters most.
Sir, suppose a patient came with acute retention of urine. On evaluation, we found CA prostate, metastatic CA prostate. So we advised him for a hormone therapy and just catheterize the patient. So how long we should wait for voiding trial? 1 month or 2 months or 15 days? Or I mean, when should do channel QRP?
Okay, I got the question. See, here is your patient who came to you with retention of urine. You are putting the catheter, draining about 1 liter of urine. Okay. And then you are doing a DRE and identifying a hard prostate, and further evaluation diagnosed to have CA prostate, which is metastatic, you say. Okay.
Right, sir.
That is what it is. Now the question is whether to offer the patient hormonal treatment, whether to offer the patient an androgen receptor blocker, or whether to offer the patient anything else at all. Okay, that is the question that you're asking. And if anything else to be done, should we defer that anything else to be done? That is, I mean, TRP, whatever. And so for some time, before that, should we offer the patient a trial removal of the catheter? And if in case a trial removal of the catheter is to be given, when to give that? Is that the question?
Sir, how many days we should advise him for voiding trial?
The patient with, you said, with the retention of urine. A retention of urine, leave alone the CA prostate. A patient with a 69-year-old male, retention of urine, and then you're putting a catheter, draining 1 liter of urine. Okay. Draining 1 liter of urine. When will you give a trial removal of the catheter? If it is not a CA prostate.
Okay.
No, I'm asking you. The thing is, the catch here is that how much of urine was drained on catheter. Retention of urine is the end point for intervention. That is one thing which you should remember, irrespective of whether it is benign or malignant or whatever. Retention of urine is an end point for intervention. That means a person who has had more than
थोड़ा 10 मिनट वेट कर लो संडे को
is a person who has had more than 800 ml of urine drained on catheterization is unlikely to improve or void well after catheter removal, because 800 ml is a cutoff that we have. For all practical purposes, we say 1 liter. The person who has drained 1 liter of urine on catheter, there is a 30% chance that he will develop a re-retention in the next 3 months. There is a 60% chance that he will develop a re-retention in the next 6 months. That is what the data show. You understand what I said? Be able to understand?
Yes, sir. Yes, sir.
A person who developed retention of urine, putting a catheter, draining about 800,000 ml of urine, the person is less likely to void on catheter removal, because retention of urine is an end point of treatment. Okay?
Okay.
If that is applicable for CA prostate, just imagine, should the patient with retention of urine, you make a diagnosis of CA prostate and that to a metastatic disease, do you think the prostate gland will regress enough for him to void effectively after your first line androgen deprivation or with your androgen receptor blocker is given? Extremely unlikely. In which case, extremely unlikely. So the question of a trial removal of the catheter, after your surgical castration or after your bicalutamide is not to be routinely advocated. But if supposing a patient, you will get a patient who is not willing for TURP, he will say that I have been passing urine wonderfully well until yesterday. Suddenly, for some reason, I developed some sneezing, cough, cold. I had some buttermilk, and then they will come with all sorts of weird explanations. They say, because of this, I had retention. So remove the catheter. You will come across such a hypothetical situation also. Not a hypothetical, very practical situation. In which case, a trial removal of the catheter, when can it be given? Can I take your question that way?
Sir, just I'm asking, as you said, all depend on Foley's catheterization amount of urine drained. If 800 or 1 liter is unlikely to, unlikely to successful voiding trial. If the urine amount was suppose 400 or 500 ml only.
Very
So,
true. Very true. Yes, you have a situation where 300 ml of urine was drained.
yes, sir.
Okay. If you had a situation where 300 ml of urine drained, you want to give a trial removal of the catheter. If you have done surgical castration, and if you had put the patient on an androgen receptor blocker for metastatic disease, the
Yes.
androgen receptor blocker, bicalutamide, will take 2 to 3 weeks for the maximal effect to reach. So, if you are going to give the patient a trial removal of the catheter, you will have to wait for 3 full weeks before you give a trial removal of the catheter. Okay.
So, sir, in such scenario, we should wait for, we should keep the patient on Foley's for 21 days. After that, we advise him for voiding trial after 21 days or 1 month. 21 days is enough.
No. See, there is no such exact cutoff figure available. The half-life of bicalutamide, so max or not half-life, the maximal effect of bicalutamide will reach in about 2 to 3 weeks. So keep the upper limit as 3 weeks. Okay.
Okay.
And if instead of surgical castration, if you have offered the patient medical castration, then the maximum levels of castration levels of testosterone will be achieved in 4 to 6 weeks. That means maximum period of 6 weeks you'll have to give. Okay. It depends on that. If you have offered the patient surgical castration, then and put the patient on a bicalutamide, in 21 days you can offer the first trial removal of the catheter. First voiding trial you can give. If the patient was on LHRH analog, you can give the voiding trial only after 6 weeks.
Okay, sir. Thank you.
That
After that, if voiding trial unsuccessful, then we should offer for channel 2 RP.
That depends on how the patient performs after voiding trial is given. Take it from there. Because primary treatment for CA prostate you've already given now in the form of androgen deprivation and androgen receptor blocker now, isn't it? And you are going to serially follow the patient up with the serum PSA level. The need for a TURP or not will be decided based on how the patient voids after voiding trial is given. Okay. Yes. Okay, I think we'll.
Okay, sir. Okay, sir. Thank you. Got it. Thank you.
You got it. Okay, thank
Yes.
you. I think if there are no further questions, I think we can call it a day.
Yes, sir.
I hope you all found it useful. I can still see a significant number of participants here. About 50 plus are still there. Okay, it's a good number. Well done, Surya. Well done, Rajan. Well done, Puneet.
Thank you, sir.
Yes. Probability of malignancy in pyrites. I think we answered that. Pyrites, that's what Rajan was mentioning. Pyrite score of 4 and 5. If you take 100 patients with a pyrite score of 4 and 5, 97 of them will be definitely malignant. Only there is a likely possible 3%. 3 of them may be benign or atypical. Whereas a pyrites of 1 and 2, you cannot take it for granted that they are all malignant, they are all benign. 20% of them 15 to 20% of them can still be harboring malignancy in a low pyrite score also. So that is the distinction you have to make. But the pyrites of 3 is equivocal. It can neither be this side nor be that side. If pyrites is 3, you take the other variables into consideration, your clinical stage of the disease, DRE findings, and the other radiological findings, and then decide on what next to be done in that regard. If at all there is any doubt, it is always biopsy that you should go straight away. Never ever assume that pyrites 3 can be benign, because even with pyrites of 1 and 2, you can never be rest assured. Pyrites of 3, you can never be feeling safe at all. Whenever there is a doubt, you should do biopsy. For pyrites of 4 and 5, if you don't do biopsy, I can understand. But pyrites of 3, if there is a doubt, definitely you should do a biopsy.
Sir, I have a question. If a patient came with loads with raised PSA,
Sorry?
if a patient came with loads with raised PSA,
I don't understand the question. If a patient with high
sir,
PSA,
if a patient came with loads symptom and raised PSA,
what symptoms?
loads,
Sir, LUTS, sir.
LUTS. Oh, patient is symptomatic. Okay.
yes,
Patient
sir,
symptomatic with high PSA.
and high PSA on MRI suggestive of pyrite 4.
Pyrites for a patient
And
with the,
on on prostate trust biopsy suggestive of prostatitis. Now, what should we do? Repeat biopsy or repeat MRI after 1 month?
there are two things which you should remember here. Forget LUTs. Okay. There are
Yes.
two entities here. One is you have done a trust biopsy, one MPMRI in favor of malignancy. Okay.
Okay.
MPMRI of pyrite score of 4 and trust prostatitis. Okay.
Right,
These
sir.
are two things. Now, the first thing you should do was whether this trust biopsy was a 6-core biopsy or a 12-core biopsy. If it is a 6-core biopsy, undoubtedly you should take the pyrites 4 as significant and should repeat a trust biopsy here. Okay.
Okay.
If it is a 6-core biopsy, if it had been a 12-core biopsy, the probability of one missing out an underlying malignancy is still 10 to 15%. That you should remember.
Okay.
A 6-core biopsy, if you do, the second biopsy, if you do, it can still pick up 30% of the tumors which are missed out in the earlier one. Okay.
Actually, that was 6-core biopsy.
If it is 6-core biopsy, undoubtedly you should do a repeat biopsy here. The repeat biopsy, either you can go for a 12-core biopsy or you can go for an MRI targeted biopsy. Because you already have an access for MRI, better to go for, because based on the PROMIS trial, MRI guided biopsy is much superior to, especially when the first biopsy has been unclear or whatever, it says prostatitis. Just because there is an element of prostatitis doesn't mean that you can rule out malignancy, because pyrites of 4 is definitely malignant, 97% chance that it is malignant. The other remote possibility is that 3% of pyrites 4 can still be non-malignant, and your patient may be one of those 3% who falls in that higher Pirate score, but non-malignant one. Extremely difficult to think of the possibility. So whenever
Okay,
you have a doubt, always go for another biopsy here.
okay,
This time it will be an MRI guided biopsy.
yeah. Okay, sir. Thank you. Okay, sir. Thank you.
Thank you. Thank you all. I think any other normal DERE with the gray zone PSA, that's what I think we discussed now. Okay. Hopefully we answered as much. Yeah, Aravind? I think this should be enough, no? What do you feel?
Yes, sir. Yes, sir. Definitely.
I think we have covered as much as we can. At least those loose ends we have tried to get together. And still, there will be a lot of gray areas in CA prostate where, if you listen to another faculty, they may give a totally different perspective. That's the beauty of CA prostate. That's how it is. Ultimately, you should derive at your own strategy and tell to yourself and to your colleagues and all PGs from the same college should all arrive at one consensus. And if you all can speak the same language, nothing like it. Okay. I think we should call it a day.
Yes,
We're almost 1 o'clock now. Shall we end the program today? Thank you all for
Thank you, sir.
the patient. We still have about 40-50 participants here. Hope you all had a useful time. Yeah, Rajan, anything else you would like to add?
Yes, nothing.
Okay, thank you.
Thank you, sir. Yes.
Thank you.
Thanks, Arvind.